For everyone with an interest in MASH, or more broadly, steatotic liver disease, Surf's Up, Season 5, Episode 9 of Surfing the MASH Tsunami. A look at some recent papers on VCTE in patient screening and evaluation starts now.
This week on Surfing the MASH Tsunami.
Patients don't respond on the whole to a blood test, so this physical factor that they see, they love, and I think it helps.
You have the opportunity to read the patient, do the scan over and over again. I think this is a very elegant way of doing it. In particular, if you're able to see other biomarkers go the same direction.
One of the things that strikes me is that commercial success will, to a significant degree, not only go to a drug based on how well it works, but how well you can predict in whom it's going to work.
At some point, we're going to probably have to recognize that, okay, this patient is not responding to this drug, and maybe we should stop for futility and cost saving and a lower risk for side effects, or we should switch to another drug, or we should maybe combine with another drug.
Hannes and I discussed, unrelated to this, on a different project today, something that's called the fibrotic NASH index, and it's a FIB-4 on steroids.
Every week, a global community of steatotic liver disease stakeholders comes together to explore the most critical challenges in diagnosing, treating, and developing medications for patients with MASLD and MASH. Join hepatology researcher and key opinion leader Jörn Schattenberg, liver health advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guests, hepatology researcher and key opinion leader Hannes Hagstrom, as they discuss recent papers evaluating the role that VCTEs can play in patient diagnosis, staging, and prognosis, this week on Surfing the MASH Tsunami.
Remember to stay tuned after this episode for this week's question of the week.
So I hope everybody had a good Easter holiday. We were realizing, the four of us who are on this podcast now, that I guess, Jörn, I didn't ask you. It's just snowing for Hannes. It's raining for Louise and me. What's the weather in Germany right now?
It's pretty pleasant during the day. A lot of sun now. A good Easter day here. I'm back from the Alps. I'm going to share that with you during my highlights, obviously. So I had some snow exposure those last days.
And Louise is in Canada, so I'm the only one that has not had snow exposure recently, but I've had more than enough rain to catch up for it. It's okay. With all that, well, I already mentioned who's on with us today. Louise, who just flew in from Canada last night. Louise, are you awake right now?
Depends on your definition of awake. I only arrived back 3 hours ago. So I'm not too sure I'm awake, so I'm going to be listening with interest.
We count on you to be more incisive than usual, because I do all my best things when I'm drowsy enough that I can't rein myself in. So that should be fun. Hannes, how are you this evening?
Yes, I'm great, except for as you mentioned, the blizzard. So I had to drive very, very carefully back home on my summer tires that I had put on my car. But I made it.
Yeah, glad you made it. That's true. Oh my gosh.
Yeah, and my best driving experience recently has been coming back from Liver Forum last weekend. I drove through 40-mile-an-hour winds and a tremendous amount of rain. I kept waiting for my car to slide off the road, but happily that didn't happen. So we were all here, and we are all here at the end of what has been a rather whirlwind couple of months in steatotic liver disease, between the Rezdiffra approval and a lot of good studies being reported and some exciting meetings, others on the horizon. So why don't we just do groundbreaker first, and then we'll start talking about some of what's caught each of our attention in the last couple of months. Brave one, go first.
I can start because I'm fresh from the holidays. I took a week off with the family over Easter, skiing in Austria. It was a lot of sun, kind of wet snow, but with some fresh snow in the morning, so you could always go for an early run. That was good. Of course, I enjoyed having the kids. Took some skiing lessons, and then in the end, they went on a couple runs with me, and it was a lot of excitement and fun. So good holiday for us.
That sounds fantastic. Next?
I'll chip in next, having just spent a really nice 10 days in Whistler, although with no ligaments in my right knee, to be able to support me skiing now after my accident in Switzerland skiing. But I was able to enjoy Whistler for other things, and Vancouver Island, and do things that we wouldn't normally do, because normally we just hit the ski slopes. But my husband carried on skiing with some friends, so I enjoyed it anyway.
I think you saw more snow than the Austrian Alps, Louise.
Oh, I don't know. When I was when I was in Switzerland, we had a meter, but you probably had a little bit of a lighter dump. We haven't had too much at this time in the year in Canada. We normally get a good load, but it's been all right. Probably not as much as Hannes is having now.
Hannes will regale us with all of his weather traumas, starting with his vacation in Nice. Go ahead.
Yeah, no, talking about skiing, I actually tried randonnée the first time a couple of weeks ago when you put on skins on your skis and you actually walk up with skis on top of a mountain, and then you take the skins off and you ski back. And that was very fun, but also extremely exhausting. And I prefer to have a lift to take me up the mountain, actually.
Okay. And then the rest of Hannes' story is he was on vacation in Nice where everything was great except the weather. He got rain there and then snow at home. So he's been exposed to about as much moisture from the sky.
I could take some sun right now.
Yeah, we all could. I guess I was telling everybody beforehand, my last 36 hours have been a bit of a joyride, but I only say that facetiously. I've had my bank account hacked, I've been sick, and I've had my computer crash. So all those things have been exciting. The best news, however, is that fortuitously, I figured out that my bank account had been hacked within 12 hours of when it happened. So the funds had not actually left my bank via internet. So I don't need to recover my money. My money is still sitting in my bank. But it's always exciting when you get a phone call being told how many submissions you've bounced, and then realizing, in fact, you haven't bounced any at all. I've learned this morning how many people I know have had similar incidents recently. We'll be intrigued to see how this one finishes up, but everything's good. My health is back. My computer is back. My money never left the bank, so everything's fine.
Well, glad to hear that worked out. That's kind of scary.
I'm still a little thrown, frankly, but nothing I can't get over. So with that, why don't we dive in? I think I kind of started to dive in already. Last 3 episodes that we've done have focused largely on the Rezdiffra approval on March 14th. But that's not the only exciting piece of news we've had in MASLD land recently in Steatotic Liver Disease. A bunch of publications, some of which some of the folks on this call are authors on, and we'll be talking about some drug news, some exciting meetings. And I think people a tremendous amount of good energy, and that's looking back, and then positive energy looking forward in terms of publications ahead, meetings ahead, and all that. The other interesting thing that I'm starting to observe in conversations is people are starting to think a little bit more holistically about what treatment might look like in a year or two as we start to see the shapes that things are taking in terms of some of the clinical trial results, some of the device and diagnostic results, and some other things like that. So I want to start by asking each of us to pick one or two pieces of research that you've been involved with or just you've read about in the last month or two that you think are particularly encouraging, and why.
So I can maybe start. So I was a little bit involved in a paper with Vincent Wong, where in JAMA, and I guess a lot of people were actually co-authors on that paper. It was a very, very nice multi-center study, and I think that sort of work is something we should do more of, so pool our resources together for a sort of a more meaningful analysis. Well, essentially just showing the prognostic ability of FibroScan to predict outcomes, and it was actually in this particular paper shown to be on par or better than biopsy. And that is, of course, very reassuring, also given the information from FDA that biopsy would not be needed in order to start treatment with Rezdiffra. And I guess that they're going to say that on all upcoming drugs. So FibroScan may be enough if you want to predict the risk of outcomes. And we also, just a few days ago, published a very similar study from Sweden with around 14,000 patients looking at prognosis. However, not all of those were MASLD, but it was a mix of patients with Hep C, alcohol, and so on. But essentially showing the same thing, that the higher levels you have on your FibroScan results, the higher is the risk to develop decompensation. And that can be used to guide people, saying you have a value of 10.2. What does that tell you in terms of prognosis? So I think more and more of those papers are coming out, which is nice in our field when we try to predict outcomes that may lie very sort of long time ahead from many patients.
Superb. Jörn or Louise, go next.
This is a notable study, and Hannes, congratulations for participating and supporting it with your data set. You didn't take the deep dive into it, but it combines over 16,000 patients with VCTE over a tremendous time span. And just looking at the abstract, median follow-up of 51.7 months. Majority of patients repeated VCTE, and from that group you derived the events, right, which showed both liver-related events but also mortality. And I think that's the type of analysis we want, kind of a real-world cohort. It's not derived from a pure study population. It's something we see at tertiary referral care centers. These patients coming in, as you said, with a 10.2, what does it tell us for the patient? When should we see them again? There's a lot of discussion of how soon should we see those patients again. And I think this is really a landmark paper and setting some of those metrics and informing us on it. Again, I think it's great.
Yeah, it's a very nice cohort, and I think there are a lot of ongoing studies using that particular cohort as well. So probably many more papers are going to sort of come out of it. What we have to consider also is that one of the findings was that you see if you improve your FibroScan levels, then your prognosis looks better as well. But we also have to factor in that sometimes it's a tricky examination to do. I guess you agree, Louise. I mean, sometimes it's just tricky, and you get a false positive result. So what the improvement or perceived improvement actually means is just that maybe the first measurement was wrong. So we actually have it now in our updated Swedish guidelines for MASLD saying, well, if you do a FibroScan and it's high, consider actually repeating it with especially if you do it with a new sort of an unexperienced user, to ensure that you actually do a second FibroScan before you act on the results. I don't know, how do you do it in your setting, Jörn? Do you also only sort of buy the first result, or are you sometimes a bit cautious?
I've gone back and redone them myself. Sometimes you get readings where you say, well, sometimes there's an obvious problem if somebody doesn't observe the IQR, if it's been a difficult exam, and then you get an invalid reading, which of course are not reported in these type of studies. But the clinical routine, you get that, it's a 28 and you have an IQR of 75 or something, and then it's all over the place. And redo those. Sometimes I tend, if I have the patient come back, just retest them again when discussing results of labs after 4 weeks or something. It's not a time frame where you'd normally repeat an ultrasound or something, but for a FibroScan, sometimes capturing more data points might be useful to reduce that noise. In some cases, I think in many cases, of course, you get a valid first. There are some cases that are improving, and I think, Louise, that'd be interesting to hear on your experience. You always highlight that the information we get the patients changes then, or their lifestyle helps them to change their lifestyle, and then actually you can see better readings.
I think that's right. What I see scanning more of the general population and knowing people better is where you get regular scans, particularly post-COVID. You saw people's livers change very drastically when they started socializing again, drinking again, and partying heavily, and you would see their scans change. If you didn't know what their original scans were, you'd go on this one scan, you'd be referring them to a physician, and it's more inflammation. It's a sudden increase in fat, the same way that we can suddenly decrease fat over a very short period of time. And for some people, we will see that react. We talk about it when we talk about Hep B, and you'll get the flares through the enzymes during the year, but we never take those bloods regularly enough to see those flares or to see what's going on. And I think we do have an opportunity with FibroScan to be able to add it to a routine investigation every time you come in, see what's changing. The piece of research actually that interested me recently was a piece that Jörn's involved in, and it was Angelo Armandi and your team doing the short-term reduction of dietary gluten improves metabolic dysfunction-associated steatotic disease, a randomized controlled proof-of-concept study. Now, you use the CAP here, and over a very short period of time, you saw quite a reduction in the CAP, which is what I tend to see when we talk about interventional therapy. And yes, any device that probably measures steatosis can do the same, but you see the behavior change, and then pick the right part of a diet to change in people. And a lot of gluten-rich products are those products that are sweet, donuts, biscuits. So when we talk about changing the sugar content of somebody's diet, I looked back at a client that we have who's done this. When they drop the sugar out of their diet in all shapes and forms, biscuits, sweets, cakes, particularly apple pies, they drop their liver fat. But when I read this study, was that because they removed gluten, or was that because they removed more of the high fructose and sugar content, or was it a bit of both? Because it was really quite marked, 1.1 kilo weight loss and defatted from 275 to 230 within 6 weeks. So I was really interested in this little piece of work that I picked up, Jörn, so you might be able to tell us a little bit more, because it does focus on the CAP rather than kilopascals.
Yeah, thank you for highlighting that study. That's in short, in fact, a single center intervention we did. I try to offer all my patients something, and the ones that do not qualify for clinical trials based on advanced MASLD, typically I don't want to send them off to the primary care physician. So we've done all types of dietary interventions over the past, and gluten reduction is one that actually is simple because because you have a lot of gluten-free dietary products in the stores these days. It's sometimes easier than if I start to discuss, the protein, fat, carbohydrate content of the diet. And so we did this as a proof of concept. The ups and downs of CAP, we used the SMART exam, so we captured a lot of CAP readings here, not the 10 readings like it used to be in the days, is that CAP has a little bit more variability, of course, than the elastography, the VCTE, I think, but a robust reduction, particularly reaching 30% is something where we do believe in the change in intrahepatic fat content. And I think this is how we're going to deal with it in real life practice down the road. The patients are going to go on a diet on intervention. We're going to do a FibroScan. It is a prognostic biomarker based on what Hannes and Vincent Wong and co-authors have shown, and we use it to guide us on treatment response. Now, there's some pitfalls to that related to BMI and variability of the reading as we have, but as you have the opportunity to read a patient, do the scan over and over again, I think this is a very elegant way of doing it. In particular, if you're able to see other biomarkers go the same direction. You can pick the weight, you can look at the transaminases, all things that we're going to be able to do. And I think this is the way we're going to be dealing with Resdifra too. We'll use those simple biomarkers to assess potential treatment response.
So Jörn, I haven't gone through that paper in sort of detail, but congrats to it, of course. But we did maybe a similar thing, and I think the thing we learned that it's more about the calorie intake that can be reduced when you switch a diet. Did your patients also in the active arm then, lose weight? And was it the effect on CAP? Was it mediated through the loss in BMI in general, or do you think it actually was the gluten content that was the bandit here?
Yeah, that was our hypothesis based on actually preclinical models supporting that gluten does cause some innate immune stimulation. In particular, not gluten, it's a subfraction of glutens, the antitrypsin inhibitors. And I have to say, a limitation within that study is we do not have in-depth assessment of dietary intake. So I cannot give you the details of caloric intake of the individual patient.
Which is also very, very tricky to measure also because you need to trust what the patient is telling you in a questionnaire, and that's super tricky to remember what you ate 2 weeks ago, right?
It's one of those tricky things in lifestyle interventions. I agree. However, we did train them to a healthy diet and repeated that in a telephone interview. So they had 2 trainings within 6 weeks. So there was some cutting down. It was not weight effect alone that we saw, and there was a small difference in weight, but we didn't find that the BMI meets a short study period too. It's only 6 weeks really, and it speaks to some of the challenges also to maintain. Those are not people that are gluten sensitive in terms of developing obvious disease. So their motivation to avoid gluten is even more difficult, and gluten avoidance, it's very tricky. In that short-term period, we didn't see a weight difference. I think it comes down to, as Louise said, some of the content of the diet being less carb-rich and bringing some of those contents down.
Exactly what I was thinking also. But I guess it's a nice way of showing, like, if you really want to do a gluten-free diet and you think you can adhere to it for a very long period of time, then it might be beneficial for some patients.
I think, Hannes, what it also shows is that people will change parts of their diet. They may not record it in a clinical trial level of input, but they see a change. That change modifies behavior. That behavior then becomes more consistent. And I think for the real world population, outside of the big clinical studies and the big FibroScan studies going on in Europe now, which are all going to be patients more than real world. Whereas when I do real world, 33% of our Australian cohorts and people just walk through the door, they've all got fatty liver. Very few of them have got NASH, but they've got fatty liver. So they want to see that reduction in fat. They want to make a change and be able to get a quantitative improvement. If they're working with a dietitian, if they're working with a physical therapist, if they're working in a gym, we can now reflect some of this, and the data's there to say that we can see it. And I think, can we put more of this into primary care? Can we take this out and make a change to squeeze, I suppose, upstream to stop people getting to MASH? Because we can now tweak little things and show them the difference. That's what we're now getting to with the non-invasive therapies. And that's the big win for the resmetirom approval and no biopsy, is that we are now going to look at all of the other NITs to be able to say, well, what can we gain from it? Patients don't respond on the whole to a blood test. So this physical factor that they see, they love. And I think it helps.
Yeah, I totally agree with that. That is sort of some sort of biofeedback, right? That you have when you do an intervention and then you see a result. So my takeaway here was just mostly that also when you do an intervention, some people are very motivated to do this intervention for some time, but unfortunately, if you say that this is the only solution that will work, and then people are going to try it, and some are going to fail, unfortunately, and they're going to feel bad about it. But if we can show that there are actually multiple dietary things you can try, okay, maybe this didn't work for you, but try this or try this, then we're in a better position, I think, because then people can choose a little bit what suits them. And I think the important thing in the long run is having a sort of a sustained weight loss and not doing this yo-yo thing, which is probably quite harmful, actually.
I think it comes down to the individual preferences of what the patient can adhere to. I mean, it's not that gluten-free diets are the solution for MASLD, but it shows you it works. And I actually went back to the publication on this. They do have a different BMI in the end, and there are multiple ways that you can do that. I think if you can give them a simple tool, they can self-implement that. It's helpful, and we have those metrics for the NITs to measure these days.
I think this is fantastic. So first of all, for those who don't listen to this podcast all the time, you know that we always adhere strictly to the outline that we start with. We didn't start with much of an outline today, but we've already blown it to smithereens in the first 23 minutes. I like this conversation a lot better. But the point I was going to make, Jörn, jumping off what you just said, is that the more control you can give a patient over their own therapeutic regimen and the direction they're going to go, the better you're going to do. People do well what they do well. They do poorly what they do poorly. So the more diet choices you can give, the higher probability of success you're going to have in a mass population, because people will have more ways to go to succeed, and some will be easier for them and some will be harder. That, I think, is the first takeaway from this that's really important and really helpful. The second takeaway is that FibroScan is at least somewhat accessible. If you go to the States, one of the things that's happened in the last couple of months is that eScopics has launched commercially with a different device, but it's a VCTE-driven device in terms of the analytics, and it's got a very different cost and reimbursement structure than FibroScan does, which may make it more accessible in primary care offices and other locations, which means that over time we will have the ability to track patients in more different settings. Between the work that FibroScan, that EchoSense is going to do, and making FibroScan more available, and then having competition. I've said this a few times on this podcast, that what I used to tell my marketing clients is that when you only have one competitor in a space, the issue is, well, do I do it or not? And as soon as you have a second competitor, the question changes from do I do it to what do I use to do it? So the presence of this data, the ability to show that more different kinds of diets can be helpful and can be measured as helpful using VCTE, and then the presence of a couple of VCTE competitors should make it a lot easier to manage patients at large in the society, which I think is a usually good thing. Every good thing has a problem, which is the more we talk about this, the less incentive there is for any patient to do clinical trial anymore. Every good side has a bad side. The FDA not requiring biopsy for prescribing of Rezdiffra at the same time that they're still requiring biopsy for clinical trial designs. If biopsy is one reason patients don't want to go into clinical trials, makes it even tougher to do that for first-line patients. And the fact that we don't have standard of care, and we're still talking about using placebo control groups as the control, is a second. So at the same time that we're making this a lot more enticing for patients and doctors, we're making it a little more complicated for clinical trials. And one of the questions I'm going to be asking every session that gets even near this topic over the next few weeks is, do we believe that the kinds of papers that we're talking about now will ultimately move FDA or EMA further down the path of not requiring biopsy in clinical trials? Because if you talk about major breakthroughs in the next couple of years, that as much as more drugs would be a huge one. Just throwing it out there. Does anyone have a thought on that?
I guess your guess is as good as mine, because I'm not really sure how the FDA works or what makes them make decisions here and there. But I guess the more evidence we get that non-invasives are also prognostic, and changes in non-invasives are suggestive or predictive of changes in risk. And actually what could be even more meaningful right now is showing like you have a reduction due to something. So you have not a falsely high FibroScan result leading to an improvement, but actually a treatment. So if you can track that, for instance, with weight loss, you can see that, okay, these patients have a reduction of 20 kilos or whatever in weight, and then the FibroScan levels improve, and then the prognosis is better. Then those kind of studies could probably be more persuasive also. But in terms of exactly what the requirements are, I'm not sure. But what are your thoughts on this tricky topic?
Yeah. I mean, one thing is the availability of the exam also, and that's why we need to provide primary care and care providers with easy access to an affordable diagnostic tool. And they have to be able to actually bill the patient and the healthcare system to provide that. And in Europe, that's not as straightforward as in the US, based on the way of the reimbursement of diagnostic testing, which is typically not specifically reimbursed unless you get a specific code and you have to apply for them. So it's a long story, which is doable, but it needs to be more thoughts on how this is achieved down the line, in particular in Germany. So I wanted to share something with you guys that you might have heard of, is that there was a big EU consortium that's recently been kickstarted, which is called LiverAIM. Now, this consortium wants to use diagnostic testing in patients, randomizing 100,000 people, 50 versus 50,000 in testing versus no testing, and showing that testing actually does impact outcome. I mean, the study you now presented here, Hannes, shows that changes in the NITs do predict outcome. But the question is there a rationale to screen patients, and do we have prove to show that screening is effective, cost-effective, and does save lives? And I think for liver disease, that's quite a hard burden. And the excitement that this EU consortium brings, which is going to be funded for 5 years now, is that this type of large-scale randomized trial for diagnostic testing is actually going to start soon. And that's going to hopefully answer some of those questions, whether we should start screening and which patients should be screened, and then see what comes out down the line. Big trial. Will be many more years until we get the results, but it's good to have it done at one point.
It's super nice and super important, and very impressive of all the contributors to the project, of course. And I think it just shows that exactly what we need. We're still sort of a small field, and we need really to come together and do these kind of big studies in order to really change what people think. So huge congrats to you guys for doing that.
Jörn, can I ask, a lot of liver units and things that I know, they're still struggling to keep up to date with their current workload. To add that sort of large capacity on causes issues with capacity in the NITs, but also in the experience, as Hannes said earlier on the podcast, in the context of the experience of those people doing those scans. For me, FibroScan is not only a diagnostic tool, it's a treatment. When you give a brief interventional therapy and you talk to people, I don't know how the protocol, I've not seen the protocol, to be fair, is controlled. Is it just a result, or is it brief intervention at the time? Is each different area doing something different? And will that be detailed so that you can see the effect of the NITs being used versus the behaviour change and stuff? But how much drilling down? Because that's a vast volume of patients to be bringing in.
Yeah, sorry. So the primary endpoint is really the outcomes data in patients that have been screened versus not screened. The ones that are identified undergo a brief behavioral intervention or more intensified therapy if they're advanced disease, but that's not the primary outcome. You cannot introduce multiple interventions in one clinical trial. Even if you enroll 100,000 patients, then you randomize and do something different. That's not feasible to be answered within that study. Still, the patients will be offered some solutions. The workload you were addressing, I think in a lot of places, hepatologists are still not using the available biomarkers to actually sort out the referral pathways. I think that's why we've been working on that so intensively. If you ask a referring physician, you get sent every GGT that's abnormal, but you might not have to see every GGT that's abnormal, and you really want to see those advanced liver disease patients. Now, that is difficult because it takes educating your referring physicians, being in close contact with them. Who do you want to see, who do you don't want to see? And every time a primary care tells a patient, you should see a hepatologist, and then the hepatologist says, no, I don't think I have to see that patient. There's a certain, there's a lot of need of communication with the patient, with the referring physician. Well, why don't you see that patient? And it goes all over again. And that's kind of the workload. I think the time we have better NITs that tell us this patient is likely to have an outcome that's going to benefit from as a hepatologist, my consultation, then we can actually hopefully focus on the right patients. Maybe not decrease the workload, but kind of increase the ones that we can have an impact on.
The other thing that I did think about, and I think it's important, is the psychology that the patients come from. Each different country has a different system, and different people react differently. A British patient going through their different system, whether they've been hospitalised, institutionalised, and placed in that sort of system and become that way, or they've been kept independent thinkers. We've discussed it earlier, this whole way of motivating and empowering a patient. Different systems work on different ways that patients are paternalised by physicians or healthcare practitioners. That is going to, are you measuring that? Because that is a vast amount of countries with all different types of patient psychology. And unless you have that, you just can't say that this is going to do this and this screening. Because I often say it's not about screening for liver disease. Maybe that's not cost effective, but screening for heart disease or fatty liver that affects heart disease and diabetes. that may be more cost effective. But the psychology of each of those.
That's always the challenge in Europe, where you have multiple medical systems and reimbursement systems running in parallel. So if you have clear measures, you can capture that. And we're hopefully going to, there's going to be confounders in different countries, but we're going to capture those and hopefully come up with a result showing that there is useful screening for liver disease, or for screening for advanced liver disease in patients, maybe not in the general population, but in the at-risk population.
So being the only person on this call who lives on what I'm going to describe as the west coast of the Atlantic Ocean, I'm struck by the idea that all this energy predates the approval of a drug. You come over to this side of the pond and you're going to have all those same issues, except now you're going to have a drug on top of it. So it will amp the energy around the idea that solutions are possible, but I'm not sure the tools are in place. I know Naeem talked a while back about his concern that exactly what you just described, Jörn, happening in one way in Europe will happen in the States, which is an awful lot of primary care are going to send patients on to the hepatologist. Now, in his case, he was concerned about FIB4, but there are lots of different ways to get to sending more patients to the hepatologist, and the hepatologist needs to treat, should be treating, or has the time or space to be available to treat. And it's not clear to me that the practicalities around the pathways are worked out well enough yet anywhere. We've got some models, but I'm not sure that we've got practicality.
I agree. And there was a review a few months ago in Diabetologica sort of arguing against the topic of screening, because with the current pathways we have, it's going to lead to a lot of overdiagnosis and over-referral. And hepatology is a small specialty, so we really need to construct our pathways so it's so simple enough that primary care can essentially do a lot of the workload itself and demystify a lot of what we currently are doing. Like, what does a FibroScan measure of 11.1 mean? If you're going to send that back, not just that number to a primary care doctor, they're never going to know what to do with it. So I just talked to a primary care doctor for another reason, and they were sort of like, we don't want education on diseases, we want education on symptoms. They don't want education on, or at least the one I was talking to, didn't want education on, for instance, MASLD. You want education on elevated liver tests, for instance. So what should I do in this scenario? Because they don't, at the point they are seeing the patient, they don't really know what they have, right?
Yeah, but you're describing primary care as triage, aren't you? When you do that, fundamentally.
Yes, exactly. But then the triage will need to be as good as possible to not triage 40% of the patients onwards in the system, right?
So I agree with that. What I suspect will change that will be the availability to give a simple testing solution to primary care. Primary care is confident treating diabetes right now. A large part of that is because of glycohemoglobin, right? You have a single test. Everybody knows what it means. It means the same thing in every setting. And therefore, you can administer the testing and be confident with what you've got. I'm wondering, listening to this conversation, whether VCTE has the potential to be that. Because it's clear when you look at the work that's being done on the various liquid biopsies that they, and in fact, a lot of the machines, MRI-PDFF, for example, are going to be more responsive to some mechanisms of action and some modes of disease than others. And this is a complex disease. It isn't one disease, it's several diseases. So the question is there going to be any screening technique that's going to be good enough to bridge all that? What I think you guys are suggesting collectively is that if we knew enough about VCTE, that might get close. Or am I overstating?
Time will tell.
Time will tell. That's a good one. It's not a test we can give the primary care physician to test all patients, right? So we need it as a specialist test in a two-step way, or specialist clinics like Louise is offering. It can't be the first point-of-care test. We need something simpler, potentially automated, an algorithm that's running. We've discussed this in the back end of medical records. Hannes and I discussed, unrelated to this, on a different project today, something that's called the Fibrotic NASH Index, and it's a FIB4 on steroids, maybe. It has some more aspects related to comorbidities with A1C and HDL in it. So, that could be another solution, and I think that's run in diabetes clinics quite frequently. Honestly, I went back to the paper after we discussed today, and I think we have to push the message on FIB4, but there's maybe more than one way to achieve our goals.
Yeah, I think I agree. But we will all like FIB4, but it's not the perfect test. It's designed in HIV/HCV patients. Of course, a score like FNI, which might also be possible to improve, but it's designed to pick up MASH plus F2 to F4. So it's sort of designed for our setting. So it's quite quite clear that such a test would be probably better than to use a model. These are mathematical prediction models, and it's not very simple to do those. Well, it is actually too simple to do that, but it's hard to do them right. And now I will promote a recent paper one of the postdocs, a mathematician, statistician in my group, just published in JHEP a few weeks ago. It's a review on how you can think when you want to do a new prediction model, with me and Peter Jepsen, also epidemiologist, hepatologist in Denmark. So if you want to do a prediction model, read that paper first, because the first sort of idea is that you probably shouldn't do it.
So elaborate a little bit on why not to do it.
You're saying we have too many of those.
Yeah. The problem with prediction models is that you can do a prediction model pretty simple, but it's usually going to be wrong, and you're going to have too many. We're already in the field right now, but if you look at other fields, there are more like 200 breast cancer prediction models. And if you have 200 models, which one are you using? None. You're just inflating the whole field. So instead of course, we all want to publish nice papers and so on and get the fame and glory. But what the field really needs is like finding one good model instead and sort of coming behind that one. I think that's the way we need to go.
And I think coming back to your question, Roger, VCTE, what it does is it doesn't matter. It's non-discriminatory. It assesses the liver that's in front of it. So you may not know what that person's got in a disease. But coming to Jörn's point about the gamma GT and names, when we've approved it recently for NICE, for primary care or non-specialist setting, to be able to put it into primary care, it is strongly linked to the current pathways. So these are, and the GPs were very keen as part of the whole process to say that we will only be referring people to our community and to have our own clinics for FibroScan for those patients that we would have referred to a hepatologist, to screen out the ones who don't need to go to a hepatologist. So by screening the abnormal gamma GTs in their local area, in their clinics. But what we also have is a number of opportunities to educate primary care, where we've put it in Southampton. They've got an excellent model. It reduced their referrals to start with, but it actually then filtered a lot more of the more severe patients in and educated primary care about better patients to select to be assessed to go to specialist care. So I think there's a lot of steps in any of these devices going into a community setting, because at the moment, as Hannes said, GPs want to know about symptoms. Well, the most symptoms are very nondescript, as we know, and then you just can't scan all of those. So we do need those filters, the FIB4s and all of that, to try and detect that. But we need access to these non-invasive tools like eScopics and FibroScan and things like that in an area to filter the right patients through to the specialist settings and more specialist tests. It's a funnel system. Not only can it funnel in, it can funnel out. Go back to your primary care. They've got access to FibroScan. They can continue to monitor you, and we will bring you back should we need you. So there's lots of work that can be done in redefining pathways now in a more appropriate way with prognostic and monitoring NITs. And we're not yet there. Our pathways are years behind where our technology is. We have until we get them right now with the technology, we're going to struggle.
Yeah. It's also an important point, Louise, like when do we stop actually determining risk for our patients? At some point, it's going to be probably futile to keep a patient in the pathway. If you are 65 or 70 with F0, then it's very likely that you will never experience cirrhosis. So should we then, have a cut point where we stop in some patients? But that also reflects, if you're high risk, you have diabetes and so on, maybe you have a higher risk and you might actually want to keep them in the loop. But refining our pathways to make them more individualizable is also, I think, an important step we need to do in the future, because at some point we might say to patients, well, you're actually sort of free to go, so to say. We were talking a bit that before when we talked about different diets and the patient should be able to choose and so on. But I guess in a not so distant future, we will also probably have a number of different drugs, and it will be extremely interesting to see, what will be first line treatment, second line, third line combination, and so on. And given that resmetirom seems to work, but we mustn't forget that for most patients, they did not respond to the drug within 1 year. Of course, they might respond if you keep treating them. We don't know that yet. But at some point, we're going to probably have to recognize that, okay, this patient is not responding to this drug, and maybe we should stop for futility and cost cost saving and a lower risk for side effects, or we should switch to another drug, or we should maybe combine with another drug. So we're going to have to do a lot of studies to build that framework also, to see what should the treatment pathways look like, when do we stop treatment, when do we switch treatment. So and I don't have any answers.
Yeah, this brings us into the topic of the type of biomarker we typically have not discussed so intensively here, which is the predictive biomarkers, right? Typically we talk prognostic or diagnostic, but predicting who is going to respond to which treatment, that's really something we haven't seen a lot of. And the Madrigal people have published a biomarker that actually responds to thyroid hormone receptor beta agonism to measure with this sex hormone binding protein, which goes down in patients that are being exposed. Now, there was not a very strong correlation with histological treatment response, but I think it went that way, and we need some refinement of existing biomarkers to actually predict that. And I think, Hannes, it's probably not going to be the biomarker, because all the type of biomarkers we're using today, because the biomarkers are coined for liver histology, and I'm not sure they're really coined towards the mechanism of action of the specific drug. I mean, even if you consider a GLP-1, we've seen patients improve their liver health, albeit not losing a large amount of body weight. So there are some things that are more complex than predicting response based on one biomarker. And I'd like to see a specific biomarker for each MOA to understand when to change, how to change, and which other drug to use. That's going to be a lot of interesting.
Yeah, and then I partly agree with you, Jörn. I think we're going to that would be the optimal scenario, but it also sort of complicates the treatment landscape, and it makes it even more difficult for allowing primary care and so on to treat these patients, because if they're going to have to come up with, you also have to know these 4 mechanisms, and you have to take different blood tests each time to check for treatment response. It's going to be tricky for people to keep everything in mind, and the pathway algorithms we need to do will be impossible to fit on one page probably. So that means we're probably going to be sort of treating these patients in hepatology for at least the first few years when we have drugs on the market and so on.
At the risk of sounding like a pessimist, from the day that the cholesterol hypothesis became reasonably well accepted to the day that statins became widely available, you're talking about a period of 30 years. From the day that Nixon announced that the U.S. was going to start the war on cancer to the arrival of pembrolizumab, that's about 45 years. So we're talking, if we think we can get this right in 7 years, we're really heroic. I got to tell you, Hannes. I'm hoping that my kids get to see this compared to my grandkids, because it certainly isn't going to be around for me. But
it definitely takes more people like Hannes and his group doing all the science.
I'm a very, very impatient person, Roger. So, but some things you can't control, I guess. So, yeah, we'll see.
Look, we're more advanced in terms of how we think about these things than we used to be. And listening to you, one of the things that strikes me is that commercial success will, to a significant degree, not only go to a drug based on how well it works, but how well you can predict in whom it's going to work. Because the real misallocation of resources here will be about giving the wrong drug to the wrong patient once we have the ability to give the right drug to the right patient. And there, Jörn, I think your point about predictive biomarkers comes home to roost very, very powerfully. The better job you can do of predicting what's going to work, or failing that, predicting what a fast failure looks like. If I can look at adipodectin or something and figure out in 16 to 20 weeks that this isn't getting anywhere, that's multiply helpful to the system. That would be my thought.
I think the other added complication onto that here, Roger, is resmetirom has been approved for those who are on dietary and exercise programs. Now, we have to therefore be able to monitor those patients that are on those programs to say who's not responding to them, who should be responding to them, have they responded enough, do we add resmetirom in all of those groups, and which one of those groups does better. Now, we can only do that if we already have serial fibroscans during those programs, or escopics or any of the other devices, to know that they're not responding to be put on a medication to then get futility. So there's all of those little branches, but it has been approved with those two things, not on its own, without. And a lot of our systems are not structured for that.
Yeah, Louise, I think this is kind of scary for the hepatology field because we haven't done that. But that's actually how all the labels it's how all the diabetes labels read in the US. So this is the same for GLP-1s. And I think physicians are going to be pragmatic as well as patients in deciding how the baseline therapy is going to look like, which undoubtedly we need. And that's the way we wanted to show it with a short pilot on gluten-free diets. We need to offer the patient something, but I don't think this is going to be a major restriction.
In the States, it's no restriction
I
at
don't
all.
think it's a restriction. I think it's exciting because we have to focus on it a bit more.
Louise, although in the States, we don't. I mean, it's in the label, and people pay as much, prescribers pay as much or as little attention to it as they choose. They just don't worry about it. One of the jokes around statins 25 years ago was that you were giving people license to eat more frankfurters and hamburgers and get their cholesterol down all at the same time. So the focus isn't on, okay, first let's do an extensive diet and exercise protocol. Let's track that protocol. Let's see how that works, and then add drug if we have to. People tend to add drug earlier. Now, what's interesting, though, is that the labeling in the States talks about, we talked about this, I think, in the patient advocate episode a couple of weeks ago. The labeling in the States talks about the idea that the drug should be an adjunct to diet and exercise. But in reality, it tends to work the other way around, which is that primary care does not get particularly committed to treating a disease if they can't give a drug. But once they can give a drug, they're more likely to push on diet and exercise for the incremental benefit that it provides. So there are going to be all kinds of complexities around this. But I agree with you. It's helpful that all that is recommended. But how it gets used from country to country and specialty to specialty, I think will be very different.
I really want to do a study where you randomize patients to GLP-1 or resmetirom or whatever we're going to do, or a personal trainer plus a free gym card, and see what's best. I can actually imagine that the PT is more
or a nurse with a FibroScan.
We'll clone you, Louise.
What I'm thinking, though, is now you're in Scandinavia, and now we're back to Mr. Fit, right? Where, in fact, you could prove that if you get people to comply with lifestyle well enough and the drugs aren't that good, the lifestyle effect in the placebo group will swamp the drug effect. So and to be careful what you wish for, you might get it category. I'm not sure what happens if that's what the result proves out in this case. That's that cholesterol back 20 years. So we'll see. All right, we're getting to the bottom of the hour. This isn't the episode that I had in mind when we drew it up, but I like this one better. So I think that's good. Closing question. Look forward, say, 2 years. And what are the steps that you believe we will have taken that will actually help us do a better job of triaging patients and getting the ones who need therapy to therapy? And then if you want to go past that and get really ambitious, for those optimists out here, what we can do to then get patients to the right drug or the right course of therapy. We've talked about a bunch of things. What do we think is actually going to play out? Brave one, go first.
It's quite tricky. I do think we will probably have at least, maybe not in 2 years, but I think we might have something that's a little bit amphib for to work as a first-line screening algorithm. That can also be, with all the interest now from the industry and so on, more sort of dispersed also to primary care is easier. So I'm not seeing anything, replacing FibroScan as the second step in the near future. I do think we need this kind of two-level testing algorithm. I'm not seeing that in 2 years we will have, something that's so much better than FibroScan that we can safely use it as a first-line test and stick to that. But I'm, of course, also hoping I'm wrong, because that would be nice if we have like a HB1AC for hepatology that primary care feels very safe to use, but maybe not seeing that within the next 2 years.
Yeah, my hope is for, we've discussed this briefly, to have more manpower actually be able to advise and counsel all these patients, have more physician assistants and nursing staff trained and providing some high-level recommendations and guiding all these patients, and really increasing the manpower to deal with the patients that might be interested in receiving that treatment, because the lifestyle and exercise just doesn't do it for their liver. That's the challenge, the workload Louise mentioned, identifying the right patients, and I hope we're going to be able to contribute to some of that with our research.
So, Louise, I'm thinking that what Jörn just said is that our Louise cloning program needs to go forward in earnest.
Well, we do have a QI program that we have designed for that can be implemented. Funny enough, quality improvement, that it can go throughout specialities, because I think one of the things I'd like to see in the next 2 years is that we look at the high-risk groups, and we're focusing on our known high-risk menopausal, postmenopausal women, for me, obviously our diabetes population. So those programs have to be implemented cross-speciality, where we're going to get the right patients from, which is the beauty of the QI, because it's cardiology, primary care, physician's assistants, things like that. Anybody we can use in that program, but you're not going to be able to just put hepatology nurses into these areas for one reason. Hepatology nurses are not specialists in MASLD and MASH. We're specialists in liver disease end stage, and a lot of this is upstream. So I think we're very good, like the physicians in our speciality areas. We have weaknesses, and it's strengthening those weaknesses across the board from a practical perspective, but patients are very good given the information and given the responses, and they want to try really hard. That whole aspect in this next 2 years, I think they will be driving us. They know there's a drug there. Whilst it wasn't for resmetirom, I did see adverts in Canada for herbal liver, but they're talking about fatty liver on a TV screen, just adverts that you pick up. There was at least 2 or 3 of them. So there is a conversation going on a broader spectrum. So I think patients are going to be looking for us now. And I think that's always a nice place to be because it drives GPs. It drives the right next decision. That's where I'd like to see it going in the next 2 years. Personally.
Mm-hmm. So as I'm listening to this, here's the thought I'm having. The testing that will work best will be the testing that empowers patients to do the right thing. A, by giving patients who are motivated cues for what to do. And then B, over time, by helping providers understand how to work with patients on this. The idea we started with that different kinds of diets can all have an effect is, I think, important because that gives consumer choice, even in the absence of medication. And now you can say, well, you can help yourself this way, or this way. And giving choice, I think, is a limited number of successful choices is pivotal to behavior change. So I think that's issue number 1. And then issue number 2 would be to figure out how to make the results of these tests readily understandable enough. The kind of thing Louise talks about where you can watch patients, you can show them 2 numbers and they can track themselves. That's pivotal number 2. And then number 3 will be, as I think we're probably a year and a half or 2 years away from seeing significant consumer promotion of drugs themselves in the space, maybe even more than that in the States, and obviously more than that in Europe. But when we start educating patients that there's something they can do, then I think the rules will change fairly quickly once they believe that. With that, let me thank you folks for taking over the agenda and doing a much better job with it than what I had in mind. I'm delighted about that. I will be back, audience, with question of the week and business report in a second. Let's everybody say goodbye. And
good to see you all.
Bye-bye.
Bye-bye now.
Good to see you.
Goodbye.
Bye.
And now, here's Roger with this week's question of the week.
And here's our question of the week. We just spent the episode talking about the role that techniques like VCTE and 3D ultrasound will play, or even can play today, in screening, staging, and determining prognoses for MASH and MASLD patients, and then thinking about what that might mean for the future of patient treatment and clinical care pathways. That was our question. Now it's your turn. What do you envision the role that office scanning techniques like VCTE and 3D ultrasound will play in the future of patient screening and the development of clinical care pathways as compared to computed tests, either simpler ones like FIB4 or more advanced ones like NIST2+.
And now for the Season 5, Episode 9 Business Report.
Slava Ukraini, glory to Ukraine, and also Am Yisrael Chai, the people of Israel live. U.S. Congress is still in recess this week, but it's widely reported that Mike Johnson plans to pursue a Ukraine spending bill when they return next week. This will be excellent as long as it provides the level of support the Ukrainian people really need. In the meantime, I marvel at what Ukraine is doing with drones sent to Russia to attach energy sites well past the border. These people are remarkable. In Israel, the push for Bibi to go has reached fever pitch, which is, I think, a good thing. The best hope of getting the hostages back and finding a viable long-term solution appears to lie in his departure, which will also aid the ability of people in the States and Western Europe to focus on the increase in the horrible, pernicious anti-Jewish prejudice that has become so fashionable on college campuses and so despicable in its own right. Choroyam Slava, glory to heroes, and also Am Yisrael Chai, the people of Israel live.
Big events in the life of Surfing MASH are approaching rapidly.
This month, we'll achieve our 4th anniversary and, at the same time, surpass 225,000 total downloads, on our way to 250,000 sometime this spring. Wow, big number. We've also acquired research suggesting that we have over 3,300 weekly followers through the major podcast sites, and we're approaching 1,000 LinkedIn followers while growing momentum weekly. If you're in a biopharma or device diagnostics company, expect to hear from my colleague Steve Ennin or me sometime the next 2 weeks about our new sponsorship packages.
We are working out some kinks as our question of the week continues.
The kinks Grace refers to have to do with the crash of the email addresses dedicated to your answers to our question of the week. So if you have comments on this week's question, please just send them to the stable address, which is questions@surfingmash.com. Thanks.
Coming soon, the Surfing MASH publication calendar.
Within the next 2 weeks, we will release to potential sponsors our schedule for the rest of the year, including KOL guest schedules and topics for many episodes and a list of the conferences we intend to cover. Again, if you're interested in being a sponsor, you'll want to see this and you'll hear from Steve or me about it.
This week's vault comes from last summer's EASL Congress coverage and looks at the role primary care can play in screening.
Last summer, we discussed the role that primary care can play in screening patients as part of our EASL conference coverage. This conversation features Sven Franke and Ian Rowe chatting with Jörn and me about the FIB4 and related issues for primary care screening at the beginning of the clinical care pathway. That's it for this week. I want to thank our team, Jörn, Louise, Mike, Eric, Steve, as we march ahead. I also want to thank the people of South Korea who slotted us as high as 7 on the Medical 250 this week and 58 on the Tougher Health and Wellness Standard. Enjoy our upcoming conversation Saturday and Sunday. Please take a listen to the question of the week, and of course, please reply. We'll be back next week, and until then, stay safe. Surf on. We'll see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to questions@surfingmash.com and we will answer on the podcast or website. Your question might even wind up being the question of the week.